Welcome back and good afternoon. I'm Lee Mills, one of the PTAC committee members. At this time, we're excited to welcome 5 amazing experts for our next roundtable panel discussion who will share their stakeholder perspective about a pathway towards developing population-based total cost of care models. You can find their full biographies and slides posted on the ASPE PTAC website. At this time, I'll ask our panelists to go ahead and turn on their videos if you haven't already. I'll briefly introduce each of our guests and give them a few minutes to give some introductory comments. And after all 5 introductions and comments, we'll have plenty of time then to ask questions and engage what we hope will be a robust discussion both within the panel and with PTAC. First, we have Dr. Dawn Calcagno, Senior Vice President and Chief Population Health Officer, as well as the President of Advocate Physician Partners at Advocate Health. Welcome, Dawn.
Great. Good afternoon, and thanks for having me. I am not a clinician, just to be clear, but I do want to thank everybody for your time today. I appreciate the opportunity to be here and really to talk about this timely important topic. By way of background, I'm the Chief Pop Health Officer for Advocate Health, which is a large non-for-profit IDN that covers 6 different states. If you see the slide here, we are privileged to serve about 2.4 million patients in over 110 value-based contracts. So we have any type of contract from upside only, downside, professional cap or global cap across Medicare, Medicaid, commercial, or ACA lives. And the way we do this is across 15 different networks that are consistent of both employed and independent physicians. 5 of those networks are MSSP or REACH, and if you break those down further, 3 are MSSPs, 2 are in the enhanced with significant downside risk, 1 is Track C, and then we have 2 REACH programs. 1 is primary care capitation, and 1 is total cost of care capitation. Collectively, these 5 networks serve about 250,000 beneficiaries, 77% of which are in some significant form of downside risk, meaning greater than 40–50%. Collectively, if you look at this, our MSSP and REACH organizations have saved about $750 million since about 2015. Our experiences, as you see at the bottom of the slide, tell us there's 3 key success factors. Number 1, the adaptability to policy change. And what we mean by this is you have to be willing to participate early in any of these CMMI, Medicare waivers, or even commercial ACO risks. One of the things I like to say, though, is you need to do it with a purpose. It can't be a side hustle or something some department's doing independently of itself. The second part of adaptability that I want to be clear with is sometimes these programs change, and so that stroke of a pen can immediately change the dynamics for the better or for the worse, such as in BPCIA or REACH changes. So adaptability is key success, number 1. Number 2, size, scale, multidisciplinary clinical integration across the continuum is key. As you talk to people across the country, some point fingers at specific stakeholders in the value chain, thinking that the cost is a particular person's problem or provider type problem. We actually firmly believe that inclusion of primary care, specialty, hospitalist, post-acute are the only way you're going to succeed in true total cost of care models. And one of the things we point out as an example is Advocate Physician Partners, where I'm president of currently, is a 4,500 physician clinically integrated network. It includes employed and independent doctors, primary care, specialists, post-acute networks, hospitals. And we've been clinically integrating for the better part of 2 decades. And the results are clear across all forms of lines of business of our success. So we firmly believe that's a key success factor. And then the last success factor I'd throw out is the sophisticated pop health platform. You may think of it as infrastructure cost, but to succeed, you do need advanced analytics and risk modeling. And all that starts with just capturing and organizing the data, which is not easy, nor is it cheap. But it also requires equal parts of focus on prevention, as well as managing acute episodes, and often through team-based care, such as pharmacists doing metformin dosing. And then lastly, we'd say evidence-based protocols that are tied to a learning health system are absolutely key. You can go to the next slide. So if you take those 3 key success factors, we really see them manifesting themselves across the domains PTAC's interested in today, as you see in this chart. I'll just call out 2 areas. At the basic level, and I consider this table stakes, just the willingness to participate, there's several areas you can focus on, but the general theme comes down to this. 1, there's a cost to participate, either very clearly financial, or secondly, as an opportunity cost. And two, you have to consider the opportunity to improve care and be financially beneficial, not a deficit for you. So we think that's what causes people to decide to participate or not participate. Once you move on to the advanced level, however, the theme gets a little different. And here we think to be advanced, you do recognize the role of the hospital, the specialist, the primary care, that you have to manage across the continuum. Now, you'll see at the top there, we do believe there are a need for different degrees of flexibility in the models. The way I engage a specialist might be different than how I engage a primary care doctor. And then lastly, we'd say, think about risk adjustment differently. It's not about HCCs. It's factors like frailty, SDOH, polychronic conditions, et cetera. So the current model that we are in today, or the current environment, as you see at the bottom of my slide, there's a lot of competing CMS or CMMI programs. We firmly believe this leads to fragmentation. I'll give you an example. When oncology care model came out in 2015, our integrated oncologist joined the OCM model, and it impacted the network by allowing the oncologist to put cost into MSSP while capturing more money themselves. Today, we see the same thing happening with comprehensive kidney care contracting, CKCC, versus MSSP. And then it's even little things like identifying participating providers. MSSP does it at the TIN level. REACH does it at the TIN NPI level. So Advocate alone had to spend over $100,000 creating a separate TIN to be able to participate in REACH. So thank you. I look forward to the discussion today.
Thank you so much, Don. Next, we're excited to welcome back Dr. Mark McClellan, Director and Professor of Business Medicine and Policy at the Duke Margolis Institute for Health Policy at Duke University. Welcome back, Mark.
Thanks very much. It's great to be back with PTAC and great to follow Don and be on such a terrific panel. Go to the next slide. Just a few comments I want to make to start. First off, some disclosures that people might view as relevant. Next slide. One of the things on that list is that I am one of the co-chairs for the Healthcare Payment Learning and Action Network, which reference in the background materials for this meeting is showing that while we have made some important progress towards whole person or person first care with some direct intentional link to total costs and important outcomes for the population treated, we still have a long way to go. This varies across programs. What I would note is two things. One is that CMS under both the current administration and the previous administration have been consistently committed to this goal. And if you ask private payers, or for that matter, most other stakeholders, most of them believe that these shifts in payment and shifts in care models that those payment shifts can support are part of the future. So even though this has been slow progress and a long way to go, not a sense that there's a better solution out there. So that's why this meeting is so important. Next slide. I'd say just a 40,000-foot level, made considerable progress in getting these kinds of models adopted into primary care. I think that's a great place to start. Without advanced primary care, as many of these models have shown, it means more resources, more reach throughout the care continuum. It's very hard to build up a coordinated, longitudinal, sustainable care model for Medicare beneficiaries as well as across other payers. But we still have a ways to go in these other key circles I mentioned here: specialized care, integrating social services and support, integrating technologies. Drugs are still paid for pretty much on a fee-for-service basis as all of these shifts are happening. And even within primary care, still some more work to do. So I'm going to focus on this next slide for the remainder of my time, some ways to accelerate progress towards the 2030 goals that CMS has put out, and we're referencing these materials 100%. We're about 25% overall, larger in primary care, less, I'd say, in specialty care and our overall healthcare system. So quite a ways to go. And this is something that the other panelists have mentioned too, getting to predictability around the long-term outlook for these models. CMMI and adoption in CM have shown, and adoption in Medicare Advantage and now Medicaid Managed Care more have shown that a shift away from fee-for-service into more person-based payments for primary care supplemented perhaps with fee-for-service payments for additional kinds of services is a fundamental approach that seems to work. I'm not sure that CMI needs to keep setting up additional models separately on 5-year tracks to add into that. I think probably more important to have predictability that while the details may continue to evolve, as Don mentioned, there will be different levels of moving away from fee-for-service. There will be a sort of a high-end direct contracting or REACH type option that goes beyond the 2 or 3 years left in any particular one of those models. An overall framework that I think there's a growing amount of consensus to support, and it should be a continuing area of focus for further development. Related to that, multi-payer alignment is key. There have been a number of studies, including a few more just in the last month, showing that even primary care groups that are pretty far along are facing 200 or more performance measures that are covering a lot of the same things. And we just don't have that on the fee-for-service side, where there's a standard CMS developed and backed set of CPT, ICD, DRG type codes. There's a lot of effort underway, and I mentioned it in my appendix slides, in the Healthcare Payment Learning and Action Network to support multi-payer alignment at the state level and with national healthcare payers and purchasers. People can't realign their contracts on a dime, so asking people to join the CMS program in the short term is tough. But again, with those predictable signals about where we're going, there's a lot of interest in getting on a pathway towards increasing directional alignment, not just on measures, but on everything else that matters, benchmarks, data sharing, et cetera. Third, we have a lot more work to do on specialty care. Some good models like Don mentioned for kidney care, where the nephrologists kind of coordinate all of care for oncology care that can plug into these comprehensive models. CMS is moving forward with their team model, a mandatory version for short-term common episodes and procedures that are hospital-based. The big missing area that is on the CMS strategic priority list is longitudinal primary specialty coordination, where there are a ton of good ideas out there that are being taken up in advanced Medicare Advantage plans with subcapitated primary care and specialists that are in the same network, moving further away from fee-for-service care, in some employer plans and Medicaid plans, finding ways to build these nested models. Again, you need that primary care whole person base for these models to work, but supporting them, for example, by giving specialists who are participating in these models more flexibility to bill on a person basis to support those longitudinal care coordination steps instead of just getting paid for the procedures and the admission under fee-for-service. That's an important area for further steps as well. Next on the list is making sure that our payment models are really based on person-focused longitudinal care, not fee-for-service. At some point, we'll know we've kind of gotten there when these models are no longer called alternative payment models, but they're kind of the base. This is an example of how this is still playing out. When we set up the Medicare Advantage program, I had the privilege of being there at CMS. We were looking for a way to do risk adjustment to make this accountable person-level care work. This was in 2004, 2005. Best available data, of course, was fee-for-service claims at that point. If you were designing risk adjustment today, getting to Don's earlier comment, I don't think you'd be using fee-for-service claims. I think you'd be using data that can now be captured accurately and reliably through multiple modalities and incorporated into clinical dashboards and care supports that clinicians think really matters. Things like frailty, things like functional status, multi-morbidity, social risk factors, et cetera. Those are all doable today. It's just very hard to do in the traditional model, and it's leading to some growing challenges in applying a fee-for-service reported data, which is often missing for some of the biggest chronic disease risks based on fee-for-service practices, which are not representative of these emerging successful models. So transitioning to more modern data can be less burdensome and can get a better basis for aligning care reforms with the performance measures that we're using in these now hundreds of billions of dollar programs and getting bigger. Also, with this evolution in making the alternative models more the norm, person-based care the norm, is recognizing that if we have a good core structure to build on, shifting from 5-year evaluations to more rapid learning approaches where more contained steps can be tested. Things like ways of sharing data more effectively between primary care and specialty providers. Things like making those adjustments in the models that are inevitable as evidence improves and technology improves, making it more predictable in ways in which can be piloted with participants and with CMS and maybe with other payers. Rapid learning is an area where can complement these 5-year big long-term evaluations. Got a lot to say about engaging beneficiaries too, but I think we've got some other panelists who have also some excellent ideas on that. So I'll stop there and thank you for the opportunity to join.
Thank you so much, Dr. McClellan. We're happy to welcome back as well Dr. Palav Babaria, Chief Quality Officer and Deputy Director of Quality and Population Health Management at the California Department of Healthcare Services. Welcome, Palav.
Thank you so much for having me back. And I think as many of you probably know from last time, I serve as our department's Chief Quality and Medical Officer, and in that capacity, responsible for all of our value-based payment initiatives across the California Department of Healthcare Services, which is our state Medicaid agency here in California. So a few just grounding facts and figures. In California, we currently cover more than 14 million individuals. So on average, about 1 in 3 Californians are enrolled in Medi-Cal, depending on what part of our state you're in. Sometimes that proportion goes up to close to 50% or more, and in other places, it is a little bit lower. More than 65% of our enrollees identify as people of color, and we also have an outsized coverage of children. So we cover about 40% of all births in California, and about 2/3 of the children who are enrolled in Medi-Cal identify as Black and Latino. Like many other states, we also really bear the majority of care and payment for individuals with complex needs and unmet care. So more than 2/3 of all of our long-term care facility days are covered by Medi-Cal. And then we currently also have a number of justice-involved initiatives that are ongoing, where about 80% of individuals cycling through our correctional system are also eligible or enrolled in Medi-Cal. So I give those backgrounds, as you heard from some of the previous folks on the panel, multi-payer alignment is critical. And in California, it is hard to find practices that are caring for Medicare Advantage or Medicare fee-for-service patients who don't also have a significant footprint in the Medi-Cal space, just given how big our program is in California. You can go to the next slide. So I tried to keep it really simple and focused for our feedback for this committee. I think the multi-payer alignment is critical. We, as a state Medicaid agency, have definitely been on a journey to improve alternative payment models and improving and supporting total cost of care models for all of the reasons that this is also being explored in the Medicare program. We recognize that as we approach our managed care plans, because about 99% of our 14 million individuals are enrolled through a managed care plan, and then their downstream providers, doing this and having broad scale uptake is really contingent upon how simple can we make it for practices. For some of our practices, they are working with 5 different Medi-Cal managed care plans in their geographic region. They then have additional Medicare plans that they are working with, commercial lines of business covered California, and it does definitely, lead to exponentially worsening sort of burden to do all the reporting, to track the quality measures. So we started several years ago, and we're part of the HCP Land State Transformation Collaborative to really bring together at least the public purchasers in California. So DHCS covers about 14 million people. Covered California is our state health exchange, covers an additional over 1 million individuals. And then CalPERS is our state retiree sort of pension public purchaser, who I think is the second largest purchaser behind the federal government of healthcare insurance. And so collectively, we cover almost about half the state. And so we've aligned across us 3 purchasers. So that link that's in the slides here is our contract language that all 3 of us, it is almost identical, inserted for our managed care plans about what our expectations are for downstream alternative payment models and primary care spending that we are requiring consistently across our 3 organizations. We now have a state entity called the Office of Healthcare Affordability that did not exist when this multi-payer alignment contract language was issued few years ago. That State Department and office is now issuing further guidelines statewide for how we're going to achieve total cost of care targets, how we are going to move into establishing benchmarks and requirements for both primary care spend as well as alternative payment models. And so we are updating our sort of prior multi-payer alignment to now align with that statewide effort. But we have gotten great feedback that I think that has, at least brought more of the public purchasers to the table. And definitely, I think, as was mentioned before, figuring out, how do we do that across Medicare and Medicaid, especially in states where Medicaid is a significant payer, is going to be critical. And exploring, how can some of these same efforts be spread across the Medicaid program nationally would help with that alignment for providers that really serve both populations. The second bullet here is really around strengthening and centering primary care. As Mark McClellan and others pointed out, there is no future where we can really achieve total cost of care targets that does not involve improving and changing how primary care is practiced in America today. And I say that as still a practicing primary care clinician who sees patients every week, that exactly that fragmentation, lack of care coordination is, we all know, resulting in completely unnecessary and burdensome and costly utilization. And so we also have very specific targets around what we expect of primary care and have aligned those expectations and targets across those same public purchasers in California. And then the last bullet is really, we recognize, as you saw on that slide right before this, that states are very different. We all have very different demographics. Within Medi-Cal, who we cover, is different than who my other public purchasers are covering, who mostly are covering older individuals, retirees, fewer children, fewer pregnancies, and really thinking about how do we take a quality measurement approach that can span the totality of all of the populations, but then be sort of, create subcomponents that individual practices can adhere to, even if they don't cover all of those lives, is really critical. And when we have explored, greater participation in some of the federal models as a state, that has often come up as a barrier, that the model is really, designed for Medicare and does not exactly translate to the Medicaid world. And if we are going to actually get to this multi-payer alignment, thinking about that upfront and figuring out how do you do measurement on a full population basis and think about some of those subpopulations will be really critical. Thank you.
Outstanding. Thank you, Dr. Babaria. Next, we're excited to have back Dr. Mike Chernew, Professor of Healthcare Policy and Director of Healthcare Markets and the Regulation Lab in the Department of Healthcare Policy at Harvard Medical School. Welcome back, Mike.
Thank you so much. It's great to be here. It's a terrific panel. I've enjoyed the comments that have been made so far, and hopefully mine will be somewhat synergistic. I'm looking forward to the discussion. So first, a disclaimer. What I say today is going to represent my personal views and don't necessarily reflect the views of organizations I'm affiliated with, and that is just an easy way of saying I'm speaking as me, not MedPAC. Anyway.
Michael, you're muted. So if you could start at the beginning of this slide, you're still muted.
How about now?
No, you're good. So all we heard was MedPAC, and then you were muted.
Yeah, I'm speaking as me, not MedPAC, but we'll go on. I only have 2 slides, so I'll give you my main thoughts. The first one is, I'm not a fan in general, or at least not a big fan of the test and diffuse paradigm that was put in place. And I think this is going to be consistent with what a lot of folks have said. And I think we're kind of moving past it, which is the performance of any given model is going to depend on other available models. One thing that I thought was really interesting, Don said, was how many models that they have at advocates. So issues around which groups do you put in which models, and remember, everyone is trying to decide which models to be in, and it creates a lot of, I think, confusion, some burden, and maybe some challenges in getting all of the benchmarks and everything right when you're juggling a whole bunch of different models. So I don't have a problem with different models, but I think you have to be very careful when there's too many models and you're launching them all similarly. There's a separate concern that happens, I think, between episodes and population-based payments, and there's been a lot of discussion of population-based payments, which is the models can end up siphoning off savings. So, for example, if you avoid a post-acute stay, which is an important thing to do, and you have patients that could be in one model or a population model, if you run the models at the same time, the savings can get siphoned towards, say, the episode model, not the population-based model. So it's hard to get the population-based model to work. And so you have to think through how these models are going to work when you have multiple people claiming that they're the folks getting rid of the waste. I tend to be a fan of population-based models. I think that's the only way that you're, broadly speaking, going to get to system-wide reform and allow organizations within their own context, so in this case, say Advocate, to build episodes that they need internally to try and engage and work with specialists in a whole bunch of ways. So that'll be my view of how to build those models. I also think there's a big concern with some sunsetting models, and this is, I think, very much in the spirit of what Mark said in terms of giving a long-term vision of where you're going. If the models of a few-year trend, and you got to take a lot of investment to make them work, it's one thing, Don, when you said there's a cost here and you have to think about how to manage the cost when you tweak it, but when the whole model might go away, your real ability to commit and invest becomes actually quite challenging. And so I think we just really need to think of this as we're transforming the way payment is done more so than we're testing a bunch of things and now we're going to launch a bunch of new models, because that's what we do, is we launch models. So the MedPAC recommendation is basically to create a portfolio of synergistic models built around a foundation of population models and add episodes, and this part's important, where the episodes are synergistic with the underlying population-based model. So where you think you can really add to savings synergistically, as opposed to, well, we needed a model for this group, or we needed a model for that group, or even worse, we didn't have enough models, so we put some more models in. I think you really have to worry about that sort of mindset of building more, diffusing more. I think the key point is to improve and execute on the models that you have. So I'm not saying the model should be written in stone and never changed. I use the word tweaked. But I think you're going to have to learn and tweak things, but I don't think it's going to be successful to continually redesign, sunset models, redesign models, and then relaunch new models with different program parameters in a whole range of ways. The amount of effort it's going to take organizations to figure out, is this model good? How's the benchmark working? I think it's just way too much to get real system transformation. So next slide. I should have said last slide. So here's my top few, four-ish design and policy issues. Number one, avoid the ratchet. You can't have organizations that succeed get paid less in the future. There's a number of ways to deal with that. They have a prior savings adjustment that deals with part of it. There's regional benchmarks that deal with part of it where they blend it in. I'm a fan of something called administrative benchmarks. Administrative benchmarks is closer to what they do here in Europe. I happen to be in Amsterdam. It's not exactly what they do, but they get a sense of a budget. And then you have to live in the budget, and you have rules for how the budgets go up and down. And you aren't ratcheting it based on your performance or the performance of everyone else in the market. So everybody's chasing everybody down. And eventually that model is going to lose. Because you're going to get to a point where you're not going to be able to save more money. So I think we need to think through, whether you agree with me or not, it would be a wonderful discussion, but we really have to think through how to avoid the ratchet of being a victim of the organizations that are successful. You want the successful organizations to really be able to succeed long run, not just in the short run. Second thing is you have to improve the ability to detect stinting. Mark said a little bit about quality. I broadly agree. I won't go into my ideas about how to do that, but I think there's one view, which is reward everybody and try and make sure that, everybody's getting paid more if they're doing better. And I don't have a, philosophical opposition to that, but I think it's much more important in these models that you worry that they're under delivering care, because that's what their incentives are. And you need better measures to make sure when that's going on. And those measures and the systems around those measures might not be the same measures as you would come up in a quality measurement program like many of the ones we have now. Third point, I think the key thing here is don't micromanage ACO activities. So a lot of people think, well, we believe that they need to set contracts not just at the ACO level as population-based, but they need to push that population base down to the clinician level, or they need to engage specialists with this type of contract in a whole bunch of ways. My general view is success is context dependent. And what they do at Advocate's not going to be what they do at MGH or wherever in California. You're going to do things differently. You have to allow the organization's flexibility to do that and not expect that you can build a contract that says, even if it worked on average, this is the way every organization should manage their internal incentives and reward systems and implement payment models. And so, again, I think that matters. Sometimes you'll have salary. Sometimes you may need a bonuses for productivity. Organizations have to be able to do that. The key point I'm trying to make is ACO success requires flexibility of the organizations to build the programs that they need to build to be successful in their context. And you shouldn't have limitations based on the regulations where they're making decisions about what they're doing because of the regulatory requirements as opposed to what they think is efficient for delivering care. Last point is there's a lot of stuff going on the Hill and a lot of discussions about how to support primary care. There's the alternative payment model bonus. I have some ideas about the design of that we can talk about later. But there's also primary care capitation policies. There's a physician pay bill, for example, that's going to primary care capitate, subcap primary care. And then there's a bunch of global service and care management codes. Largely, I typically call them the G codes, and they've had a bunch, they've changed a bunch. They all have this sort of flavor, providing some level of subcapitation, particularly for primary care in the case of ACOs, maybe for total capitation. Those things all interrelate. So they create incentives for what programs you want to be in. And I don't know who, Dawn, you can send me an email about the person's name, but someone's got to be running a analysis to see what works best for advocate health, given that there's all these new programs running around. And will we actually be better if we went back to MIPS and took the partial cap through the G code as opposed, with less risk, as opposed to the total cost of care model, which a ratchet that's moving us forward in a ratcheted way. And this sort of complexity of decision, even when I listen to myself talk, I realize how complex it is. The complexity of all the decision is such that I think the core thing to do here is to slow down and try and build something that's more synergistic, that works together, and not continually launch new things to try and get at the same basic goal of creating payment models that allow and incent efficiencies. So I think that's my last slide. So I think we're going to go on to Charlotte, but I'm glad I didn't. If I had another slide, I was going to be surprised. So you're up, Charlotte.
Very good. Thanks.
You're going to get introduced, I think.
We're thrilled to have Dr. Charlotte Yeh join us again, founder of Yeh Innovation, Chief Experience Officer of Cherish Health, and former Chief Medical Officer of AARP. Welcome, Charlotte.
Thank you very much. So I just want to be clear that I'm going to be bringing in a number of perspectives. I've been an emergency physician for over 20 years, and that is really highlights the underbelly of the healthcare delivery system and the shortfall in the community and social support. But I've also been a policy and regulator as a CMS regional administrator. But most importantly, for the last 16 years, I've been part of AARP as their chief medical officer in the business community, doing a deep dive into the consumer engagement within the private healthcare sector. And finally, the beautiful part is I'm free of organizational constraints. You're going to hear my personal insights since I am now free, and I'm an advisor now for age tech, for innovation, for healthy aging, and bringing together all of these experiences. So next slide. So what I'd like to say is kudos to PTAC and the staff, and I love our panelists. I would say ditto to everything that they've said. But I believe that there are two major omissions that we have in these alternative payment and total cost of care models that if are not addressed, these programs will not succeed. First and foremost, I really haven't heard anyone short of Mark saying beneficiary engagement, anything about meeting the needs, wants, expectation for the beneficiary. You can build the most beautiful program that invites every provider and specialist and primary care to participate. You can build it, but the beneficiary won't come. And we'll dive into that if we do not create the kinds of incentives, infrastructure, and support structure to be meaningful to the beneficiary. Why would they sign up? And the second is, the second major omission is we talk about fee-for-service, and we talk about the payers in fee-for-service as they're all uniform, and they're like every other payer in the system. And the answer is they're not. About 21% of Medicare beneficiaries actually pay out of pocket for a Medicare supplemental plan. That is 41% of people who are in Medicare fee-for-service. That is, and there are another 18% that have retiree benefits, supplemental plan, another 10% that are dual eligibles. These payer sources are very, very different. And Medicare supplemental plan is extraordinarily different because if we improve the ACOs and they're billing for more Part B and physician office visits and physician services, which overall saves money, you're actually hurting a Medicare supplemental plan because they don't achieve the savings because they pay it out in Part B, and the Part A savings, reduced hospitalization, ED visits, et cetera, actually go to Medicare. And then secondly, the Medicare supplemental plans have the real opportunity to dive deep into the consumer. So I'll talk a little bit more about that in a minute. First, back to the beneficiary. I think where we have forgotten is what's meaningful for the beneficiary. So to try and keep this simple to understand, I call them my 5 C's. The first is cost. We talk about total cost of care, but how many of you are actually measuring the total cost of care to the beneficiary, their family, and their caregivers? Right now, caregivers provide about $600 billion annually on out-of-pocket expenses that are unpaid and unreimbursed. About 21% of the cost, and it's about $7,000 on average by a caregiver, about 21% of that is on home renovations. So that if you want somebody not to fall, you've got to build in safety bars. You got to have safety maneuvers. You got to have monitoring systems. You have to have wide enough doorways. You've got to accommodate wheelchairs, walkers, et cetera. So 21% of the expenditures are home renovations. 17% are medical costs. 6 out of 10 caregivers say that they are actually being asked to do medical services and procedures that they've not been trained to do. And it's not just in the out-of-pocket expenses, but it's also time. There's one study out there that says right now your average Medicare beneficiary spends about 3 weeks going to and from in medical visits. That's 20.7 contact days. And about 11% of Medicare beneficiaries spend 50 days or more in contact with healthcare. So what are you doing to make the time efficient? Because what happens is anywhere from 12 to 30% of caregivers are either cutting back on work or leaving their jobs in order to provide that care. Where are you in the ACO and in the beneficiary services thinking about the time money? And finally, it's resources. About 20% of Medicare beneficiaries are solo agers. So the amount of services you need for a solo ager are very different than the ones I've just described who are paying out of pocket as a caregiver. But what about hearing loss? Did you know that about 2/3 of all people 70 and older actually have significant hearing loss, and yet it's not paid for by Medicare? But more importantly, 49% of people who have a lot of trouble hearing do not have a primary source of care. How are you going to engage someone if they don't know how to communicate? How many of you are bringing into your virtual visits captioning, speech to text? How many of you are using speech to text in the office? So you make it convenient, you make it, and you make it easy for someone to communicate. The second C is convenience. I just told you how many hours it takes. Right now, on average, a Medicare beneficiary has to wait a month in order to get an appointment. 1 out of 6 Medicare beneficiaries is told to go to an urgent care center because they can't get an appointment. If you're going to bring in all this technology, are you going to do it as a single platform, turnkey operation? We know that through ARP studies, about 2/3 of Medicare older adults that are 65 and older say that technology and all the services you're providing are not designed for them. We know that in ACOs and healthcare systems, they're designed around the workflow of the physician. Where are you designed around the workflow of the patient? And think about the capacity and capability not only of the primary care, but the capacity and capability of the patient and their family. The third C is for choice. I think this is way undervalued in this whole picture. Why do you think 21% of people stay in Medicare supplemental, in fee-for-service Medicare of the total Medicare beneficiaries? Because they want the freedom of choice. They want a doctor they trust. They want a doctor who looks like me, not necessarily that's assigned. They want a specialist that will meet their specific needs. And how about the ones that spend some time in their home, but they go visit their children? You know, are you taking into account that maybe they are going to be getting care from multiple sources? And don't underestimate how important that choice is connected to having trust. The fourth is coordination. I've heard, you know, it's been recognized. I'm going to dive into that a little bit deeper when I talk about opportunity for success. But think about the coordination, not only of medical care services, but that caregivers are spending about 13 hours a month just managing insurance, appointments, just the administrative costs of trying to take care of themselves. What are you doing to reduce that time? And you bring those value, the beneficiaries will come. And finally, lastly, compassion. If you don't build in time for touch, time to hold someone's hand, time to help them through crises in life, there's a study out there that ARP has identified 1 in 2 older adults, in the last 2 years, 1 in 2 older adults have gone through a significant transition, whether it's health issues, retirement, issues with children moving out, loss of a spouse. If you don't take these pieces into account, you will not allow your primary care and your specialists to do their best job. So, and then finally, you know, that may sound daunting and we can't possibly think about the beneficiary, but this is where can we work with our Medicare supplemental plans, for example? So at my time at ARP, we worked very closely with our Medicare supplemental plan and did care coordination for the high risk and most complicated patients. We found that disease management didn't really work, but if you did whole person care, as Mark alluded to, we had a reduction of hospitalization, reduction of ED visits, reduction of falls, and we had a positive ROI that could range anywhere from 2 to 1 to 3 to 1, and in the most complex patients, as high as 7 to 9 to 1 positive ROI. So that opportunity exists, but you have to understand how to do consumer engagement. And what was really unique is it didn't matter who their physician was. This was a direct to consumer to coordinate their care so that they could operate with physicians. So if we did a fall prevention program, about 40% of all of the, about 40% of the people we called about opportunities to prevent falls called their doctors, and about 6% actually had their medications changed. If they were on a high-risk medication, 60% called their physician and 15% actually had their medications changed. So let's not forget about the lever of using the beneficiary, and let's not forget about using existing models like Medicare supplemental plans, which are 40% of fee-for-service, as an opportunity to help align the payment structure, and the outcomes that you want.
Thank you so much, Dr. Ye. I appreciate all those great introductory comments, each of you. In the interest of ensuring balance across different perspectives and questions, we'll encourage panelists to keep each response to just a few minutes. We've prepared some questions we think will help kind of crystallize all the rich strains of input we've heard. Question 1 is, what would you say are the most important factors that affect participation in an accountable care relationship at the provider level or in different kinds of geographic areas? And follow-up to that is, what are the most important strategies to increase that participation? We'll start with Dr. Calcagno, and then Chernew, and then Babaria.
Great, thanks. To me, I simplify it this way: change is hard, right? If you look at behavioral economics, status quo bias, people don't like change. So I really boil it down to our providers wanting to participate are thinking, am I going to be better off tomorrow than I am today? And then the question really is, well, what's that mean? Is it financially better off? Is it my workflows easier? Do I have more administrative burden? Or probably most importantly, can I actually care for my patient the way I want to? So when you boil it all down and start talking to clinicians from our experience, you can really say it falls in a couple categories, which I've touched on before, right? There's limited resources and lack of infrastructure in small practices, small provider groups. The work we all have talked about and do is not easy, it does require significant infrastructure. So how do we support that? Two, independent physicians are entrepreneurs, and by definition, they are looking to balance risk and reward. Now, it may be different for employed physicians, but the independent physician is definitely trying to balance that equation. And three, as I've alluded to, risk models don't really do a great job capturing real risk, frailty, access, socioeconomic, et cetera. I firmly believe that you can overcome this through better clinical integration. As I've mentioned, advocate physician partners, 4,500 docs, but what I didn't say is about a third of our practices are less than 3 physicians, several are solo practitioners. But yet they participate in these programs because we provide them the infrastructure, we provide them the financial backing, et cetera. Two, I think you have to be flexible in your model design. Being across 6 states in different markets, south side of Chicago, very different issues than downtown Charlotte. And so being able to approach physicians there or a rural doctor, et cetera, need to be able to approach them where it makes sense to them. Again, I already mentioned the application of risk adjustment, not just the financials, but even some of the quality metrics. We internally do some quality metric risk adjustment as well. And then again, I know I've said it multiple times, but don't change the rules mid-participation, right? I think Michael spoke about that as well. That drives my clinicians crazy. Hey, what you're doing, you did well. We're not going to do it that way anymore. And then from a beneficiary perspective, I'm glad to hear you talk about that, Charlotte. I really think there's a huge opportunity for beneficiary engagement. Enhanced benefits, be it access, be it reducing their out-of-pocket cost, be it helping them navigate their disease states, et cetera. There's a lack of awareness, there's a lack of education, so helping them understand why these are good for them. And then taking a playbook out of some other models out there, there's no reason we can't tailor some of these plans to high-risk patients to get them excited and engaged to what they're doing. And then lastly, I'll just add, if you think about what the other payers do, they require primary care selection. They have a very much more defined network, which I know is not always popular for people to say micro or narrow network, et cetera, but it improves coordination. And then they do offer supplemental benefits. Our MA plans, number one thing that drives them in the Chicago market is if there's a rich dental plan. So I do think there are ways to incent beneficiaries. Thank you.
Dr. Chernew?
Great, thank you. I'm going to talk about 5 quick things, but I'm not going to say much about them. One, I said in my remarks, benchmarks have to be set well, so you're not going to lose when you model this long-term. 2, Dawn mentioned this, so I'll just say it. Risk, particularly how much downside risk you're imposing, is a big deal for organizations. I actually think the evidence suggests you can succeed without downside risk. And so I would be very wary of imposing a lot of downside risk because you believe it's necessary for success. I actually don't think it is. I think I said a version of this in remarks as well. It needs to be simple. It needs to be simple in 2 ways. It needs to be administratively simple. I think admin will kill a lot of groups. It's just who wants to spend their time doing admin to participate? You really have to simplify that part. And then simplifying the choice that, remember, people are not choosing, I want to be in, I want to be out. There's one thing. It's like sending someone to a grocery store with 5,000 different versions of ketchup and saying, which ketchup do you want? It is a really hard choice to participate if there's so many things you have to weigh off and know what they are. So you really need to simplify the set of models to get people in. And then the last thing about participation that I'm going to say is, and no one said this, so it might be out of scope, is you need a certain scale to succeed. And if Medicare Advantage becomes 90% of the market, you're not going to get a lot of people in. So you really need to think about how this plays with the Medicare Advantage world. And if that's out of scope, sorry. Last thing I'll say about beneficiary engagement and benefits and stuff. And I'm glad I'm an ocean away from Charlotte when I say this. I'm a fan of aspects of beneficiary engagement, but I think it's often said without understanding the full environment. I'm not saying Charlotte didn't understand the full environment, what's going on. People have a bunch of supplemental benefits that are, say, for example, in the fee-for-service world. You need to figure out how you're going to coordinate different groups of people doing different types of things in different ways. And I worry that our desire to let the ACO manage this is actually admirable, but it is actually much more complex than you think, because now you're coordinating with what the benefit supplemental benefits are. And remember, my main thing was just make it simple to join, right? Beneficiaries do need all the things Charlotte spoke about, but they don't need everybody to give it to them, right? And so you need to figure out how you're going to do that, because the coordination across these groups, and I feel the same way about multi-payer coordination. If you want, Mark mentioned Medicare Advantage plans doing this underneath, which I think is a good idea. But the Medicare Advantage plans, if they're using prior auth and prior auth is saving money, and that money is then captured as a bonus to the groups that they're subcapitating, it becomes quite complicated to figure out how it works. So someone else on the call can explain to me how to coordinate that. I would simply end by saying, keep it simple. Don't take the money away if they succeed. Don't give them too much risk, and then you'll do okay. And be humble in what you can accomplish. I'm done with my rant.
Excellent. Dr. McClellan and Dr. Ye, any brief comments on participation?
Mark, do you want to go ahead? Or first of all, Michael, you said it correctly, simplicity. It can be done. I'd also like to say, stop playing everything and laying it on the providers, that there are ways to engage the beneficiary directly. Thirdly, we have not at all talked about the opportunity with Medicare supplemental plans that people choose so that they can see any provider that they want. There's real opportunity, but here's the problem. With Medicare supplemental plans, if we do all these quality improvement programs, if we do care coordination, they are actually counted as administrative expense and not medical expense. So there isn't the incentive to bring in where 40% of Medicare beneficiaries purchase a Medicare supplemental plan. You can't bring that payer in, because all of these efforts to improve quality and outcome and coordination of care counts as an administrative expense. That's just one example of where we could align, and let's understand who this lever is that we have yet to use. And I can say we made it simple. We had over 30,000 beneficiaries that we could demonstrate. The longer they were in the program, the fewer hospitalization, the fewer ED visits, the fewer falls. But those were all savings to Part A and not to the Medicare supplemental plan. So what can we do to bring that payer in, to work with the ACOs, to work with the clinicians, and to work with the beneficiaries, because it can succeed. We modeled it in markets, we scaled it across 2 states, we converted it to telephonic, and we continue to have the same results, including 44% less likelihood to move out of the home into a long-term facility. We're not tapping into this.
To add quickly, Charlotte and I, in one way or another, have been working for, I don't know, a decade or so on how do you get Medigap better integrated with traditional Medicare and the shift to whole person care arrangements. That was an important issue. Now, as you see, like, you know, the majority, maybe headed toward the vast majority of beneficiaries being in Medicare Advantage, because they can get more generous benefits and more generous benefits going along with those networks, which traditional Medicare doesn't do, at least not in the same way. And that's the kind of choices, as Charlotte said, that people want. The people who are left in traditional Medicare at this point generally are people who have these supplemental coverage plans or there for some other special reason. And that is a key part of the future now. It's no longer something you can just think about down the road. And also on getting these additional benefits and affordability to work, we need to give ACOs and these accountable providers more help across the whole spectrum of benefits. You're seeing this play out over the next couple of months in the Part D benefit redesign that's happening, which is making the benefit much more generous, which is great, but it means that the prescribers and the Part D plans are bearing a lot more risk than they used to. That is so much easier to do in an MA plan where you've got transparency and visibility into the whole beneficiary's care experience. You can take steps like, well, using drugs that might be costly to get costs downstream. You can have a more ability to influence what would be an otherwise more generous benefit. And that's showing up in the bids that CMS got this year and the need for this special demo. So that's something that may not be easy, but I think can be addressed, and maybe even go further and think about drug payment models, to Mike's point, that aren't just, well, let's just assume that any new drug coming on the market is going to face a lot of prior auth is going to have to set a high price since the volume is not going to be very big. It'll be 10 years before you get the volume way up and the price way down. Can't we get there faster if we're implementing all of these alternative payment approaches? So very important steps for getting beneficiary engagement, starting with affordability in the traditional Medicare program from here on out.
And I think I got skipped over.
Dr. Babaria, I was just going to say, we're prepared to comment.
No problem. So one, I know this is out of scope, but to piggyback off of Michael, in addition to really thinking about how is this kind of carried through MA, I do think, Medicaid is that other piece, because at some point, if we want this to be the norm for all healthcare payment and not an alternative model, we can get there so much farther if we figure out the Medicaid piece, and then commercial can follow, right? That you hit a tipping point across most markets and most states if you can figure out a way to do that. So thinking about where the synergies are at the federal level would be really helpful. And then I think some of our practical implementation experience at the state level is really, even if the models are different, there's a lot you can really simplify and standardize when it comes to which quality measures, what the reporting looks like across different models. And we had a lot of self-imposed wounds that we had inflicted because we have a lot of directed payment programs that flow about $5 billion annually to mostly large health systems and hospital systems. And we had designed those in a silo, and they were actually sort of adding administrative burden. The measures were similar, but not exactly the same as all of the value-based payment work happening in managed care and in our ACOs. And so we, over the last 3 years, have done tremendous cleanup and have almost 9% alignment now over measures at least, and have tried to simplify the administration as much as possible. And we're really seeing the dividends of that payoff, where even if people are participating in different programs, different models, those synergies are very clear.
Wonderful. Thank you for that. We're going to turn now to incentives. And the question is, what factors do you think are most powerfully affecting primary care and or specialty providers' incentives to participate in ACOs or other types of APMs? And what would you think would be the most important model design priorities for, given that insight to what incentives are working and impacting, what would be the design priorities to try to increase participation of different kinds of providers in total cost of care models over the next 5.5 years? Sorry, let's start with Dr. McClellan, then Calcagno, then Chernew, then you and Babaria.
Great. Well, thanks very much. I do think this is one of the big challenges ahead, and I want to congratulate CMS and PTAC for some focused, increasing attention to these issues in recent years. CMMI has a whole strategy on steps for this, and I know it's been a focus for all of our interactions with PTAC, so hopefully some real synergy opportunities for action there. As I mentioned briefly in my remarks and reflected in a lot of our work, specialty care is complex, and I do think you want to keep it simple, to Mike's point, but we've kept it kind of too simple from the standpoint of really getting specialists engaged in these models. One way I think more help is needed is in providing some models, not necessarily requirements, but just make it easier, especially for the smaller practices, the physician-led ACOs, to engage specialists more effectively. It's true that there's no one size fits all on how you want to compensate specialists who are working with primary care providers, but it's also true that if you're a primary care ACO and you're not Don size, I'm going to come back to the big ones in a second, you have a pretty tough time engaging with specialists. You're not a big enough share of the market to get the specialists to pay attention to actually engaging in forming a contract with you that works out those shared savings and new steps for collaboration. And you also don't have the bandwidth to come up with what those terms might look like. CMS has done some interesting things recently with their shadow bundles and stuff like that to try to provide at least some templates that can be used. Now, you have California, some credit on this. We're looking at what California's done around specialty engagement and some of the work that we're doing in the North Carolina State Transformation Collaborative. So some models that make this easier, and this would be a great area for a rapid learning test within an overall model. So, for providers who are in ACOs and want to work more with specialists, if there is a critical enough mass in the market of specialists, and there are a growing number of specialists that are doing this in MA, and see Larry Kosinski there too. Sonar is a great example of a model that is GI collaboration on chronic management of conditions that can't be sustained easily under current specialty payment mechanisms for colonoscopies and doing procedures. So there are some models that could work. I think they can be piloted and implemented more widely. I think collaboration between groups like AGS have been working on this. ACC, orthopedic groups, AAOS. There's some good models out there, and MA needs this too. The network models there have implemented things like subcapitation arrangements and the like, but they're still hurting, I think, for meaningful performance measures, getting to, for example, standard functional status measures for people with back pain or lower extremity disease, or standard measures of outcomes and quality of life for patients with inflammatory bowel disease. These are not that hard to do now. They're good standards out there. They just haven't been built into the models. For the hospital-based and larger systems, I really appreciate what Don is doing, but got to say there are a lot of hospital-based systems out there that aren't yet fully on board or engaged, that may have MSSP programs running to help manage their medical patients, but not necessarily fully engaging their specialty groups, which are still accountable for turning over procedures and getting those beds cleared and used as rapidly as possible while getting by in the shared savings model. There, I think you may need some more steps in the mandatory way. CMS is moving towards mandatory bundles for the short-term episodes. If you really want to get more of the payments linked to coordination, not just for the primary care doctors, but for the specialists, and linked to things like tracking functional status over time, I'm not sure voluntary is enough for these larger integrated systems. And by the way, there are a lot of large systems that are not integrated like Don's, but are more consolidated. And I do think there's some good ways to support more independent primary care practices and specialty practices to get that infrastructure. You don't have to have ownership necessarily in order to achieve these goals. And conversely, what we have seen is a lot of evidence that these larger systems don't do as well in the ACO models and do have higher prices.
Great. Dr. Calcano?
A lot of what I want to talk about is really what we've already touched on. So a couple key themes. I think Michael said it, a portfolio of synergistic models. I think if you really want participants, that's where you have to start. I can go through a litany of examples where these models competing with each other have actually caused fragmentation across the work we're doing. So I'd start there. I'd add on what Mark talked about of predictability and certainty. Again, most of our independent physicians are entrepreneurs. They basically want to be able to balance risk and reward. And if a stroke of a pen can change the model significantly, that's not going to be exciting for them to participate. And I know I've mentioned it multiple times, but real risk adjustment, I'll call it. A lot of clinicians on the call today, and I know when I talk to my physicians, both employed and independent, they don't just see a hypertensive patient, right? They see a polychronic patient because that same patient has diabetes and also has CKD, et cetera. It doesn't speak to their SDOH factors, their health disparity, their lack of access, their frailty, et cetera. So real risk adjustment that makes sense to the clinician. And that goes, I think, to the theme. I think Michael started it, but several people have said it, simplify. A lot of these programs are way over-engineered. And as a result, it's not that doctors couldn't make sense of them. The doctors aren't going to spend the time to make sense of them. Something that should just naturally make sense to the clinician would be very helpful. And then I'd add two other things that I haven't heard spoken about a lot. One, I'll call it eliminating the burden. When you look at it, again, I'll use my network. So again, 15 networks, we look across all our contracts. we have 107 different quality measures. And even if I looked at one single network, it's a very, very large number. What are the ones that really matter? How can we standardize? How can we simplify? Clinicians don't want to just check a box to say, hey, they thought about this or did that. What are the real things that are going to improve our participation? And then again, it's been said several times, but don't punish success. When we're successful in BPCIA, we're successful in REACH, the next thing we know, the rules have changed. And you saw a massive exodus from BPCIA when the rules changed. So we can't do that because that goes back to the certainty principle. And you also can't continue to reduce targets when you've had continued success. So how do you get around that ratcheting effect? So bottom line, I think at the end of the day is how do you balance all these things? I think embedded bundles would make a lot of sense. Again, that idea of synergistic models in a portfolio. But then you also have to balance that with what support and resources that you're providing. We are fortunate, as Mark pointed out, being a large system, we are able to capture some economies of scale and whatnot. But we still sometimes turn to the Care Journey and others that have access to data and have applied bundles and things like that. Is there a way to make that more accessible for folks that really are smaller practices, smaller networks, et cetera? Thank you.
Excellent. Thank you for that. Dr. Chernew.
Yeah. So first, I think we can all probably agree that mandatory will really help you with participation. So I won't dwell on that. My other piece of advice would be that just design good models and don't design so many of the models that people are confused about which ones to participate in. I'm less worried about small practice because I think if you design good models, you will get conveners and other organizations that will enable small practices to participate in ways that will allow them to leverage things that being small they wouldn't otherwise be able to do. And then my third point, and I did have a third point, was beware of episodes. So I like episodes, I understand, but you really need to think through what money is it, what do you want to have happen where you're going to save money and improve quality? So one thing is you want there just to be fewer types of episodes. You want a population health in a way that you don't need as many hospital admissions or whatever that is. I completely understand. And that money, I think we're going to agree, in many cases goes to the primary care doctor. Some chronic conditions, you might want it to go to a specialist who's managing a patient, nephrologist or someone like that. And I can understand that. But a lot of the money from the ACO savings or the savings overall is coming from post-acute care. And so you need to be careful who's going to get the money if you keep someone out of a nursing home or you do some other type of more efficient post-acute care. Is that money go to a specialist because you've now put in an episode where the specialist controls that saving? Or is that savings going to go to the primary care doctor? And if you put in a lot of episodes or you're not careful about what episodes you put in, you'll be giving all that money. My view is post-acute care is the ATM for ACOs. And if you give that money to the specialists because you've built a lot of episodes, you're giving a lot of the money that I think the population-based primary care-based systems would have been counting on to make their savings, and they would be siphoned away to some potential specialist that now controls it because of the design of the episode. So while, again, I'm not anti-episode, I actually think there's a number of ways you can in fact, I like the team model because they've really scaled back and thought about that, I think, a bit more. You can debate teams separately, but I don't think trying to find a model that fits everybody to engage them is going to be helpful if those models span savings that would otherwise go to the organizations with bearing population risk.
Great. Okay, Dr. Babaria, Dr. Ye, last comments on that topic?
I definitely ditto the keeping it simple and really supporting stability because that is really needed. On the risk stratification front in our state Medicaid program, for similar reasons, existing risk stratification models and risk predictive models are very utilization and cost-based and weren't meeting our needs, especially around social drivers of health and underutilization. So we are building our own statewide transparent algorithm to do that predictive risk modeling that is more clinically informed. So happy to follow up or provide info if that is helpful to anyone.
And then I just want to add in, because I haven't heard it spoken of, is a lot of what we've described tend to be elective and planned care. But remember, about 2/3 of care happens after hours. It's not Monday to Friday. So if we really want to get participation from the primary care and specialists, we ought to be including the emergency departments, the urgent care, et cetera, that provide that safety net after hours, which is good for the beneficiaries and may help reduce the burden of care on your clinician participants. And with geriatric emergency departments now growing, that can improve both the outcomes, sorry, Michael, but may reduce some of the post-acute care needs and actually keeping people into the home and that kind of follow-up care. I don't think we're tapping into that lever as well to help the ACOs be more successful.
Outstanding. Thank you for that. We're going to stay on the theme of incentives, but actually turn our attention to beneficiaries. And what kinds of incentives do you think are most important in encouraging beneficiary participation in the different kinds of fee-for-service beneficiaries who are not currently in an accountable care relationship? And I suppose as you've highlighted, as we've got both MA and MedSup and standard fee-for-service, how do we align beneficiary incentives to try to get the best outcome there? Start with Dr. Ye, then Dr. Babaria, Dr. Calcano.
Well, I guess I would start with, we're not measuring the beneficiary experience, if you will. One is, are we actually measuring the total cost of care that the beneficiary is spending on their out-of-pocket expenses? If we really want them to participate, it's just like you have supplemental benefits in MA, we should be allowing those kinds of supplemental benefits to reduce their total cost of care. Number two, time is money. And if you can demonstrate that you are reducing and coordinating and making the time convenient for the beneficiary, their families, and their caregivers, people will appreciate that. Make it simple for them as well, and think about the workflow of their life, not just the workflow of the practice of the practitioners. They're important. Thirdly, is what we found more important than anything else that brought people in was creating that coordination of care, making it easy to navigate all the fragmentation. And can you bring in the services that beneficiaries care about? I haven't heard us talk about DME, supplies. You know, all this out-of-pocket expense where you've got to buy your own dressings, you've got to buy, your own supplies, your own walkers, et cetera. Not everything is covered. And what are we doing to make it easy so that you can live every day simply at home? And finally, creating the kind of technology that is easy, turnkey, platform-based. Right now, what beneficiaries face is you have a different app for your blood pressure, one for your pulse ox, one for your respiratory rate, one for your temperature, one for your activity tracker. So the more we can make it convenient and simple for the beneficiaries, they will come. That's why they buy their Apple devices. It's why they use their smartphone, because they want it to work in their lives.
Dr. Babaria?
Yeah, so as a part of our transformation of Medicaid, we've actually set up a number of Medicaid member listening sessions, both at the state level that meets directly with our executive team on a quarterly basis, as well as at the regional level via all of our managed care plans. And I think this goes back to what's in it for the member and the refrain we consistently hear, right? What members don't care, am I in an ACO? Am I in an MA plan? In fact, I would say I think general perception as being in those things limits choice and limits access, and not the converse. And what they really care about is, can I get an appointment when I need it? Do I have long wait times? Is my provider someone that relates to me, speaks my language, that I trust and have that relationship with, and are my healthcare needs and preferences being honored and met? And we have we have lots of members who are in ACO and managed care plans who are having those needs met, and others who are equally not having those needs met. And I think really looking at what will incentivize and drive them in is essentially, at the end of the day, how well those needs are being met, along with the education and sort of word of mouth, for those entities that have been able to achieve those goals.
But we're not measuring that on a consistent basis. So you cannot improve it if you're not measuring and tracking.
Yeah, and we have our sort of CAPS surveys that are very poorly responded to. We only collect them in English and Spanish, which leaves out about, I think, 17 threshold languages in the state of California and are inadequate. But the more we can march towards patient-reported outcome measures and universal member experience, the closer we will get there.
Agreed. Dr. Chernew, and then Dr. Calcano first, and then brief comments from Dr. Chernew and Dr. McClellan.
I think it's as simple as this. Beneficiaries, A, don't understand what an ACO is. B, quite honestly, they don't really care until the point that they need it. And then C, all the coordination we do is really behind the scenes, so it's transparent. And my proof point on this is my father was recently diagnosed with cancer, and he didn't care, but he's on MedSup, didn't really care till any of all this happened, right? But now he has a oncology nurse navigator. She's essentially coordinating everything he needs up front. He is super excited about that, right? He loves that. So think about that as a model for the ACO. How do we make sure that coordination is front and centered for those that need it? And then how do they understand it, right? There's a whole bunch of healthcare literacy. There's particularly in my father's case, 80-year-old, not exactly cognitively all there, right? So there's challenges that you have to deal with, but I think it all comes down to, are they seeing the value of it? And they don't necessarily have to understand the stuff all the experts on this call understand, but do they see the value, and can the design make that value transparent to them?
And just to add maybe a way to think about additional benefits in traditional Medicare, an ACO, DONS, others could come up with some additional hearing assistance or other benefits they could just offer. But most of the ways that additional benefits get delivered in traditional Medicare is through, there's a billing code for it, and accounting for the copay and so forth. It's something else that could be covered. And CMS is trying to move in that direction. You've seen some additional billing codes for things like care coordination. Don, I'm not sure how helpful the additional billing codes are going to be for you all for that. Telehealth, expanded services, remote monitoring, Charlotte digital technologies, that structure helps. I think what the Center for Medicare has not quite figured out yet is, we want to allow for more of this billing to help organizations move in this direction, but how do we combine that with the overall big picture of, simply put, we want to help organizations get to not just some additional fee-for-service billing, but more comprehensive total cost of care and beneficiary management. One way to do this may sound a little bit more complex, but it seems like we're almost at the point with so much alternative payment approaches in traditional Medicare, you almost need two tiers for these additional efforts. So the kinds of concerns that people have raised about telehealth, about covering digital and so forth, mainly apply in the unmanaged fee-for-service setting, where the concern is that there be more billing. There's nobody who's overall accountable for those costs or is making sure that it's being used in a way that makes sense. So if Don's plans that are in substantial risk find these additional coordination billing codes for primary care docs, or for that matter, specialty docs, useful if they want to do more billing for digital health, great. They're on the hook for those services translating into better outcomes and lower costs. It would be a nice, clear signal that I think is confusing some providers today is, I could take these little steps towards care coordination, but I'm not really sure what the long-term models are going to be, so maybe I'll just stick here for a while. This would more clearly reinforce that the goal is to facilitate the fact that you can deliver more flexible services and better benefits, maybe even some copay forgiveness if the ACO wants to do it. If we make it easier for for providers to set up these models.
Wonderful. Last word, Dr. Chernew.
So I'm largely where Don is on that. I don't think you want to overwhelm beneficiaries with joining an ACO or not joining an ACO, a bunch of things that would be really confusing for them. The beneficiaries can choose their doctors. If their doctor's in an ACO, the doctor, I think, will have an incentive to provide a good job. I think you want to measure to make sure they're not providing a bad job. I said something about stinting. I think that's the core thing that you should worry about, and you should just not spend as much time trying to figure out new ways of engaging coordination and a whole bunch of other things. Just measure that the ACO has the right incentives and they're doing the right things in terms of costs and outcomes. And that includes patient experiences in a whole bunch of ways. I think that's the key thing. I agree with Mark in the sense that for services that are not going to be covered by MedSup, having a package that allows ACOs, if they want to offer those services, I think is valuable. But understand a lot of the Medicare Advantage benefits are financed with a pretty generous Medicare Advantage payment model. So don't think that you're paying Medicare Advantage and ACOs the same amount and then you're going to get the same level of benefits, because they're financed on a very, 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 I don't know how much more time we have, very different frame. And so you really need to think through how all of that will really work in practice, because you're not going to get the same ACOs competing with Medicare Advantage plans, given the vast differences in the mechanism for how they're paid. And I would just try and be a little more cautious about what you think you can accomplish by trying to build in a lot of programs to try and get particular types of care coordination and or beneficiary engagement. Just pay them a flexible amount, measure the amount of beneficiary satisfaction, give them the opportunity to provide things that they otherwise might be able to provide, and call it a day without worrying about complex codes in a bunch of ways. And Mark and I will have to have a beer over what to do with telehealth codes.
Outstanding. That we're going to turn to our last question. We have about 9 minutes left. I want to turn to other markets, perhaps inside the United States, perhaps outside the United States. What kinds of lessons can be learned from other markets, and are there examples of effective approaches you've seen in other markets used to address challenges and barriers affecting provider participation in value-based care that might be relevant here? So that's a wide open, tell us what you'd like us to know type of question, starting with Dr. Babaria, Dr. Chernew, Dr. McClellan.
I'm going to pass it on to my esteemed colleagues on this panel. Don't have much to add to this question.
So if I'm esteemed, and I'm not sure that I qualify, but assuming I do, I'm going to answer because I think I was supposed to be next. So I'm here in Amsterdam. I was talking to the Dutch Health Authority about what they do, but I said a lot of their things are mandatory. They have a very different system in a range of ways. It's not like they had a fee-for-service system. They decided to put in value-based models and then try to solve the problem we're trying to solve. They build systems that are just fundamentally different for how they work. They mandate insurance. Here in the Netherlands, everybody chooses their doctor. I think Dawn or someone said that, so the attribution issues aren't there. They don't quite impose the same amount of risk in the same way. There's some version of risk. They have the different insurance system. So this is a much longer question than I'm prepared to answer, but it is not a question like, and maybe there's other places that do this, but I think you'd find in the UK as well. They have a completely different system in the NHS. They didn't build a lot of models and then try and get people into models the way we're thinking about getting them into models. They did do certain similar things, but I don't think we have time to get into the specifics, at least of where I know. So maybe someone else will know examples that are more analogous to what we're trying to do.
Yeah, I think the main thing is because this is hard, and don't worry, we're not the Netherlands for better or worse, I guess. What I've seen really starting to help is this recognition that while there are differences across payers, there are common themes. A big one is we started with this stronger primary care. So I don't know any segment of the U.S. health insurance market where there aren't efforts underway to try to increase advanced primary care, team-based care capabilities, and link those to some accountability for coordinating care and managing total costs. Yes, the specific areas that Medicaid is going to focus on for that with moms and kids are going to be different than Medicare, and many of the polychronic patients going to be different than commercial, where it's more dealing with discrete issues, maybe more behavioral health and other things like that. But having the state transformation collaboratives that CMI has started to support is a good way to help get people on the same page. I wish it could go faster, and I think here maybe it's a structural issue with CMS and CMS finding ways to work together better across programs. We've talked about how CMMI models go into Center for Medicare programs. Well, if we've got a good core structure in the Center for Medicare, maybe what's needed is helping CM, telling CMMI, hey, we need to refine this previous model is not working very well? Can we do a more rapid evaluation within our existing programs? And to Don's earlier point, you know, I wish it were so, but unfortunately, having been there, CMS doesn't perfectly get everything right at the beginning. The models have to change, especially as you learn more about how benchmarks actually work and participation if it's a voluntary model. But you can make that process more expected and have processes built in to pilot changes and engage around them. And that can be extended to multi-payers too. And just back to Palav comments about what they're doing in California, it just kind of a reminder that CMMI and CMCS, you know, the state part of the Medicare program, really need to be building some stronger ties. So the state transformation collaboratives are not an exception, but they're kind of a rule as states are thinking about their waiver renewals and SPAs and other steps that should be, and the states are interested in aligning. They just have somewhat different populations and priorities, but I think some real opportunities for more synergies.
And then I would just add, if you think about just the Medicare Advantage market, the ACA, et cetera, they require network adequacy, right? So again, I know it's not high on folks' list to narrow networks, but the more, when you look at our other payers that are doing MA, ACA plans, you have to define the network up front. And because it's defined, you're able to better coordinate across that network. And I do, again, conclude hospitals, primary care specialists, and post-acute all have to be in that network. There is definitely a selection bias if you're a primary care-led ACO, if you're a hospital-led ACO. And just having everybody on the same page, again, going back to that simplified portfolio, where we don't have competing models, we don't have competing providers in the network. We have one network that can actually coordinate together. That would be the big takeaway I'd have.
And Dr. Ye.
Thanks. So I just want to add three things. One, I really want to underscore when Dawn was talking about care coordination. We found when we were using the Medicare supplement and we signed a care manager to these individuals, high risk, high cost, we could reduce hospitalization, ED visits, et cetera, because we had a trusted relationship of someone who could navigate the insurance, navigate the appointments, navigate the medications, navigate the activities and behavior changes that would have to come. And they don't have to exist only in healthcare system. There are continuing care organizations, assisted living types of approaches that provide that care coordination. And what's valuable, and to know how important it is, when they do a good job for the parents, the children then sign up for those programs. So that it can bring you back not only cost savings and better outcomes, but it can help also with the engagement side. The second is I want to underscore what Michael and Don and Mark have said about not making these changes. These care coordination programs, at least in our experience in fee-for-service Medicare, you don't begin to see those returns until at least 12 months. If we're looking for short-term gains, you're not going to get it. You have to be in this for the long haul and over time, which is really important. So I just wanted to share that piece as well.
Okay, outstanding.
Palav, you had a comment?
He is mostly covered, but I recognize we're coming up at time. You know, I think what one of my esteemed colleagues on this panel said earlier is, you know, reframing the question to be less about how do we design a model and more about how are we going to make this the norm, right? And I think everything that you've heard from the panelists so far is really when that is the problem you're solving for, you make different decisions, and it really is about scalability, bringing in those other payers, connecting the dots with sort of non-Medicare coverage to get to that tipping point. And so really keeping that at the foundation of the design, I think, will really help.
Excellent. Thank you for that fantastic final word that encapsulated it all. Thank you so much for the five of you joining us this afternoon. You're welcome to stay and listen to the rest of the meeting. On behalf of the committee and the wider audience, I'd like to thank each of you for your time and your insights and your lifetime of learning that you provided for us. Outstanding conversation. We do appreciate your time. At this point, we're going to take a short 10-minute break, and the committee will return at 3:20 Eastern, where we will reflect on the day and start discussing potential comments and recommendations for the report to the Secretary. Thank you. We're in recess.
Produced by the U.S. Department of Health and Human Services.